So we're gonna dive right into teaching mode. So we're lucky to have one of our colleagues, Dr. Sabi Effendi. He has decided to come back to visit us and talk about brain aneurysms. So Sabi is not only a great surgeon, he's a great physician. And what I like about Sabi, he's very calm. And even when things are not going so well, you know, he has a very calm nature to it, which helps to do what we do. He also has 3 children that so he's staying busy, and he's here to talk about brain aneurysm. Thank you very much for coming.
Good morning, everyone. How are y'all? Okay, so just gonna learn this clicker before we start here. Okay. And so yeah, I can go next slide. Okay, yeah, so I did train here. I was here in 2017, 2018, training with Dr. Hanel, Dr. Savageau, Dr. Nima. And so this is a picture of me and the other fellow that were here at the time. And so I'm excited to come back, talk to y'all. This is gonna be a very interactive session. If you have questions, just ask them. We're gonna kind of talk about subarachnoid hemorrhage and the things y'all see. Subarachnoid hemorrhage in general is a very first couple weeks of care are very up and down with lots of neuro changes, lots of things happening. But as the Dawn story shows, that if you can get them through it, people do make a good recovery. And so I had another picture, but I guess it's not on here. It's my wife. My wife is a Baptist nurse, so and then she moved to Houston with me. So you guys will probably meet her later too. But so this is just an overview of aneurysms. So there's different types of aneurysms in the brain. There's saccular aneurysms, which is the picture on the left. There's fusiform aneurysms, the picture on the right. Incidence of just take 100 people, about 3 people will have an aneurysm in the brain. It doesn't mean that all aneurysms rupture though. Only certain aneurysms do rupture. This is just a big graph. I just wanted to show it of like how when we see people with aneurysms that have not ruptured, how we counsel them about what their risk of that aneurysm rupturing is. And so there's a lot of different treatments for aneurysms, both ruptured and unruptured, which we won't go through in super detail, but just so you can see, I mean, we do take catheters up into aneurysms. The picture on the left is just coiling. We put in these metal coils. Sometimes if we're worried about the coils falling out, while we don't want the coils to fall out to the big vessel, we sometimes will put either a stent in or use a balloon temporarily to hold the coils in. Also, as you guys have probably seen, there's also flow diverters, which is the bottom picture, which is it's a stent that diverts most of the flow in the stent and only very little blood comes out into the aneurysm. And with time, the aneurysm thromboses, like clot forms because blood's flowing slow through the aneurysm. Here's just a picture. You can see this is an aneurysm, and you can see that there's one coil in it now. What we do is we subsequently put more and more coils in until we get an occlusion. So you can see next picture, there's some more coils, especially on the right, you can see the coils. We're putting more and more coils in until we've kind of occluded it. There's also surgical treatments for aneurysms, clipping, of course, and then also bypass. So now we're gonna get into it. And so subarachnoid hemorrhage, in the US, there's about 30,000 cases a year. It's actually, like, if you think about it, it's not a lot, but the problem with subarachnoid hemorrhage and ruptured aneurysm is the mortality is very high. It's debate. There's all these different studies, but really about 35 to 50% of people do pass away in the first 30 days from an aneurysm. Out of the people who survive, you do have survivors like Dawn who survive and go on to live a good life and even go back to work. And so this is where, like, I always tell my nurse practitioner when we round on somebody with subarachnoid hemorrhage and they're doing well, they got their aneurysm fixed. We always say they're doing well right now, because subarachnoid hemorrhage patients, the first 2 weeks, 3 weeks can be really, really up and down. And this is what I kind of want to go through with y'all, is what to look out for and why you're doing these, 14 days in the ICU, why we're every hour examining them. These are the things that happen, and they come sometimes just out of nowhere. I mean, they'll just all of a sudden, patient doing great after a ruptured aneurysm, and then they decline. And so the neuro exam is super important to catch these things. And so we're going to kind of go through each. These cases are from the county hospital when I was in training. So some of the stories are interesting, but we'll kind of go through that list of things that happen after subarachnoid hemorrhage that y'all are very instrumental in catching, and that are instrumental in improving patients. So first case, 48-year-old female. She was in a bathroom, found in a bathroom. She was screaming, altered. They found something that was like a crack pipe. Really, all we know about her when she comes in the hospital, she's positive for cocaine, positive for alcohol. And so she comes in, look, her blood pressure is super elevated, 190 systolic. She's combative. She opens her eyes. She's speaking a little. She's weak. She's following on one side, but weak on the other. So she's weak on the left side, and she's kind of combative. And so this is this. Oh, can you press play? And can you pause it right here? Ooh. Yeah, so she has hemorrhage in the brain, but then if you go a little bit farther down, yeah, like even here, you can see in the middle of the brain and the front, right here, that's subarachnoid hemorrhage. So subarachnoid hemorrhage is kind of covers the crevices of the brain, and that's how you can really tell. There'll be some more scans that you'll be able to see it better. But so this patient has subarachnoid hemorrhage and bleeding in the brain. She gets a CTA, which shows this aneurysm right here, which is an ACOM aneurysm. And so she goes to the ICU. We're trying to control her blood pressure. Prior to coiling, her blood pressure gets really high. I mean, it gets over 220. She's maxed out on cardine. Her exam declined. She was awake. Now she's not awake. She's just localizing. So, of course, she gets intubated. Her exam declined. We get her blood pressure down. She gets a stat CT head, and we end up putting in an EVD. Any guesses what could have happened? Re-rupture. Yeah. So number one thing, re-rupture. So somebody's untreated or even a treated aneurysm can re-rupture. And so somebody whose exam's declining, catching it right away, thinking about re-rupture is the thing. And so here is her scan. Can you press play on this one? This is her scan after she got intubated and declined and got intubated. And we actually put coils in. But as you can see, she re-ruptured. She got more massive hemorrhage. And so re-rupture is something that we're watching out for. And so she actually ended up getting a cranie to get that big blood clot out of the frontal lobe. Her exam improved, and she somehow walked out GCS 15 2 weeks later. Oh, yeah, that's a whole nother story. It's patients that do well. So anyway, so re-rupture does happen. So re-rupture happens in the first 14 days. Again, up to 20% of patients can re-rupture. The greatest risk of re-rupture is right when they come in. So when the aneurysm isn't fixed yet, and they just came into the hospital, that's the time where people re-rupture most commonly. And risk factors really for re-rupture, a big one is the blood pressure. And so what do we do for re-rupture? So we treat people early. If you've noticed, patients come with ruptured aneurysms. A long time ago, used to keep them in dark room and wait 2 weeks. Now that is not the case. We treat people quickly with ruptured aneurysms. That helps, of course, prevent it from rupturing again. Big thing is blood pressure control, though. Keeping systolics under a 140 or 120, whatever they want, is really important. That's the reason we're keeping it low, is to prevent this aneurysm from popping again. And because re-rupture, if you do re-rupture, your outcome's way worse too. And then, of course, if we put in an EVD, you can think of it, we don't want to drain the EVD low. We don't drain it at 5 or at 0. We usually drain it at a higher level, because we want the pressure pushing on the aneurysm from the outside, the brain pressure, to not drop. And there's stories of EVDs that got overdrained with a ruptured aneurysm and that caused a re-rupture. So we don't aggressively drain. We used to use all this, Amicar and stuff for to prevent re-rupture, but really that's kind of gone now. Okay, so we got re-rupture down, right? So we'll do next case. Okay, 76-year-old female. She's found unresponsive at home. She's got a history of high blood pressure and really negative social history. She comes in, her eyes are open only to pain. She's pupils are reactive, and she's just barely moving to pain bilaterally. So she gets intubated in the ER. She has a pretty, she's barely, she's minimally responsive at this point. Can you hit play? Oh, it's not working. Okay. No. Okay. Anyway, so she gets a CTA, which shows this small aneurysm here. And so what she had on her scan, which you can see, was very large ventricles, so really big ventricles. And so she has hydrocephalus. So first thing we did was put in an EVD for this patient right when they came in and got to the ICU. Because we started draining her hydrocephalus, she improved. She started localizing bilaterally. She ended up going for a craniotomy and clipping. The EVD, we weren't able to she couldn't tolerate a clamping trial, so she ended up getting shunted. And so this is the second thing you see in subarachnoid hemorrhage that everyone's looking for, is hydrocephalus. So hydrocephalus occurs. It can be either obstructive or communicating later on. Anywhere from, like, the studies vary. I would say anywhere from like 15 to 80% is a really wide range, but I'll say around, like in my practice, around a third to a half of patients end up with ruptured aneurysms, end up getting at least acutely an EVD for hydrocephalus. We usually, like I said, we drain it at a higher level before the aneurysm is treated, because we don't want the aneurysm to re-rupture by dropping the pressure in the brain. People who have acute hydrocephalus, when they come in, a lot of them end up developing the need for a shunt later on. But again, the hydrocephalus, it can develop at different times. Sometimes people come in with a ruptured aneurysm and they already have hydrocephalus, right? And we put in a drain. Sometimes people don't have hydrocephalus, we don't put in an EVD, but a few days later or a week later, they start developing symptoms. And again, that would be a declining neuro exam, worsening headaches. So again, another thing, if somebody has a declining exam, where we're trying to catch is hydrocephalus. All right, third case. So this is a 39-year-old male. He's had headaches for 2 days. He's neurologically intact. So this is the guy who just came in because he has severe headache, but neurologically has no problems. Can you try this? Yeah, can you pause right there? Oh. Go back up. Just right there. Oh. Oh yeah, perfect. So this is like classic subarachnoid hemorrhage, okay? These are cavities where usually CSF sits. So usually it would be black like this. This is what we call the basal cisterns, and really they're cisterns, which are fluid cavities. Basal, they're at the base of the brain, and usually right in front of the brain stem. And this is where a lot of the circle of Willis and big vessels sit. This is where the basilar sits. This is where the PCOM sit. This is where the internal carotid artery sits. So a lot of aneurysms originate in this area. And so you get this very classic pattern of when it bleeds, it goes into all the fluid cavities here. So it kind of spreads like this into these different fissures, as we call them. And so this is very classic subarachnoid hemorrhage picture, this kind of blood. And this spontaneously, if you see this ever, it's like a ding, ding, ding. This is almost for sure an aneurysm most of the time. So he ended up having a 7 mm posterior communicating artery aneurysm. And so he went, okay, so he's doing great. He goes, gets it clipped at hospital day 1. He's doing great. Then on hospital day, he's doing great, just in an ICU for a few days. And then all of a sudden he starts getting confused, lethargic. So of course, we decline exam, we get a CT head. CT head, we're looking for what? Remember, Re-Rupture, we're looking for hydrocephalus. So that's why we get a CT head. So CT head does not show hydrocephalus. It does not show any more bleeding. We send labs, they're all normal. ICP is not high. So any guess what this could be? I think I heard someone say it. It's vasospasm. Okay, so vasospasm. So at this point, we've ruled out the other things, right, that could cause this. So vasospasm. So what do we do for vasospasm? So we artificially increase their blood pressure. We can go up to over systolic of 180. This patient, we did that. Only a mild improvement in his symptoms. Still confused, lethargic, getting weak in his lower extremities. So he ended up going for an angiogram. So that's the next step. And so this is vasospasm, and I'll show you a picture right after this. But just kind of look at these vessels here. This is the internal carotid artery that turns into the middle cerebral artery, anterior cerebral artery, and then this is the other side. And so kind of look at these. This is like kind of more normal caliber down here, but they're very thin here. And then if you keep looking in that spot, that's after we injected verapamil. So you can see that the vessels became a lot bigger. And so this is what spasm looks like. This is like pretty severe spasm here. These vessels are usually 10 times that caliber or 6 times that caliber. And so vasospasm, which we'll talk about, I mean, your blood flow decreases so much to your brain that you're having a stroke. I mean, you're getting ischemia to the brain and you're developing stroke. And so he got treated. He got verapamil injections during the angiogram. He returned back to baseline. And the funnest part about vasospasm is, of course, like 12 hours later, 1 day later, it comes back. It gets worse. So he went, of course, for multiple more angiograms. He ended up doing well. Again, like spasm, which we'll talk about, if you catch it early, that's the big thing. Like you don't let it progress to the point where they've already developed stroke, and then it's kind of, you can't turn back. Really being really on top of it, and catching it and taking them to angio and starting them on the correct medicines just prevent, and it just goes away on its own. And so we'll talk a little bit about vasospasm. So vasospasm occurs anywhere from bleed day 3 to 14. Usually the peak incidence is usually around day 6 to 8 or day 7. We classify differently. There's radiographic, where just if you got a CTA or did an angio, you would see it. That happens in probably somewhere around 50 to 70% of people. It's aneurysmal subarachnoid hemorrhage. Symptomatic is like this guy, right? He started developing symptoms from decreased blood flow to the brain. That happens usually in about 1/3 of subarachnoid patients, at least. In my practice, for some reason, it's like 60 or 70. I feel like everyone's in spasm, but it kind of varies. But a lot of people develop it. And again, a spasm, you can have either non-focal signs like lethargy, sleepiness, or you can have focal signs, which are like, left MCA. You can have weakness on the right, or speech issue, just the usual stroke stuff. You can have very focal findings, really depending on where the spasm is and what vessel. Like I talked about, it's kind of a diagnosis of exclusion at the beginning, right? You have someone who declines an exam, you can't just say, oh, that's only vasospasm, right? You really have to go through that tree, right? You're going to rule out what? Rebleeding, hydrocephalus, hyponatremia. When all that's negative, you really think, okay, this is vasospasm. They usually go for imaging, either a CTA or an angiogram. So who goes in a vasospasm? Well, any subarachnoid, as you just saw, that guy who's came in really well, but he went into spasm. In general, younger people are a little bit more prone to spasm than older people. Also, how bad they come in, right? So if you had a really bad subarachnoid, lots of blood, that has been shown to, if you have more blood, that you are more prone to having vasospasm. Also, if you come in with a worse neurologic exam, like you come in, like our second case where they're obtunded, yeah, they have a higher chance of having subarachnoid or having vasospasm too. And how do we treat it? So Nematop, right? So the fun Nematop, we give that for 21 days after a ruptured aneurysm. The reason we give Nematop, it doesn't actually prevent vasospasm, but it does overall improve people's outcomes from vasospasm. So I always think of it as like, it's not like taking Nematop's not going to prevent patients from going into spasm. It doesn't. But what it does is, I think, and what people think is there's microvasospasm of small blood vessels that are microscopic, that we think that it helps those vessels. What is the treatment? Classically, the treatment of vasospasm in neurosurgery used to be something called triple H therapy, which was hypertension, hemodilution, and hypervolemia. That's changed over the years. We try to keep people more closer to euvolemic than hypervolemic, but as you know, we increase their systolic blood pressure, usually looking at cardiac output as a marker of when to stop. We give IV medicine. IV milrinone is an important medicine we give for when people are in spasm, and then also intraventricular, either through an EVD or intrathecal through a lumbar drain, we give nicardipine. That's been shown both intraventricularly through an EVD or through a lumbar drain is really effective. I think y'all were in a trial for that, weren't y'all here many years ago for this, but it's been shown that it really works. So people in severe spasm usually do get intrathecal nicardipine or intraventricular. And then of course, the last step, if you've increased their blood pressure, you're keeping it high, you've got them on these medicines, is endovascular. And usually at that point we'll go. When we go up endovascularly, go to the IR suite, angio suite, what we do is we can inject verapamil, we can inject milrinone directly into the vessels to help them dilate. And then sometimes we even go up with a balloon if that doesn't work and balloon it open. That again is temporary. And what I tell like patients' families also is like, we're doing this, but the spasm doesn't mean the spasm's gone forever. I mean, 12 hours later, 24 hours later, it can happen again and again. And that's why staying really on top of it and treating it, you can prevent strokes in these patients. And then, okay, here's the next case. So we've got hydrocephalus, rebleeding, and vasospasm. So here's the next one. For a 58-year-old male, presents with the worst headache of life associated with nausea, vomiting. He drinks, smokes, no recreational drugs, has a history of high blood pressure. He comes in, his systolic's 170. He's awake, fully oriented, no neurodeficits, doing really well. Pause it. Oh, yeah. So yeah, so there again, you saw the classic, y'all know it now, the subarachnoid hemorrhage patterns. Just right below this, you have this. Can you press play and then pause again in a few? Yeah, right there. Okay, so the hydrocephalus, he has a middle ventricle, which is some patients do have, that's not abnormal, but his ventricles are big. He's got diffuse subarachnoid hemorrhage. And we find an anterior communicating artery aneurysm on a CTA. So he goes that day, gets a craniotomy, gets it clipped. He also, of course, because he had hydrocephalus, he got an EVD. Post-op, he's doing great. GCS 15, no focal deficits. He's in the ICU, just sitting there asking, why can't I go home? We have that with the subarachnoids that did well. They're always like, why can't I just go home tomorrow? And like, my headache can do at home. I'm like, this is the reason. So post-op day 5, he starts getting confused and sleepy. Thoughts? What's the list of things that we're looking for at that point? Yeah, but what else could it be? Re-rupture, hydrocephalus, vasospasm, yes. And then hyponatremia. So this guy gets a CAT scan. Look, we're looking for rebleeding, hydrocephalus. He doesn't have that. We check labs and his sodium's low. So what do? We put him on salt tabs and a 3% drip. We check his sodium's Q6. It's like kind of goes up a little, but kind of stays the same, isn't getting better. So then after that, we put him on fludrocortisone, which is a mineral corticoid. And so that does improve his sodium and it gets back up over the next day and his exam improves. We also got a CTA, which didn't show he was in any spasm. So hyponatremia, that can also cause a decline in neuro exam. So this occurs in about 20 to 30% of aneurysmal rupture subarachnoids. So the mechanism, we all know about aSAH and cerebral salt wasting. Yeah, so aSAH really is a disease where you are secreting too much ADH and you're actually absorbing too much water that's causing you to become hyponatremic. And so it's a dysfunction in the access between the brain and the kidneys that cause you to absorb too much water that makes you get hyponatremic. Cerebral salt wasting is actually is very different. You're actually losing salt and also some with salt, and you're losing in your urine. If you're losing salt, you're also losing some water. So you actually become hypovolemic. And so that's kind of the way clinically, sometimes we try to tell the difference between aSAH, which is absorbing too much water and getting hyponatremic, versus cerebral salt wasting, which is losing salt from the kidneys. But in general, subarachnoid hemorrhage patients that are hyponatremic, we treat them like they're cerebral salt wasting because part of their mechanism is usually cerebral salt wasting. And so in subarachnoid hemorrhage, if somebody has hyponatremia, we treat it as cerebral salt wasting. And for cerebral salt wasting, like I said, you're losing water and salt from your kidneys. So you do not fluid restrict these people. If you fluid restrict them, they get more hyponatremic and they become actually more hypovolemic. And so really, like, it happens sometimes even in my hospital, like they'll fluid restrict somebody who's ruptured aneurysm and hyponatremic, and you just see their salt and sodium even drop more and more. So really, we try to give these people fluid. We're not like bolusing them, but we do put them on fluids, usually not colloid though, just NS. We start salt tabs and start 3%. And the last treatment for cerebral salt wasting is fludrocortisone. Do y'all use that here, Christy? Yeah. So that's really kind of the thing. It's very different than aSAH. So really, in subarachnoid hemorrhage, hyponatremia is treated as cerebral salt wasting, which is a different mechanism. And as you guys know, like aSAH, like with tumor patients and other patients that have hyponatremia, we usually fluid restrict. But for this, just remember, subarachnoid hemorrhage, no fluid restriction. And then, so we've got those down. Here's the last one. This one's really more just to know. You'll see it maybe once or twice in your career. It's kind of devastating when you do, but it's hard to treat this one, but we'll talk about this. Cardiopulmonary issues. So here's a 61-year-old female who presents with headaches, vomiting for 3 days. She's lethargic initially, and then she had progressed to unconsciousness, and that's why she came or was brought into the hospital. She's obtunded on exam. Her eyes, she only opens her eyes just to pain. She's nonverbal, and she's extending bilaterally. So she has a pretty poor exam. If you could pause it a little bit more, a few more. Yeah, here. Yeah. So she has, you saw that subarachnoid pattern. She has even subarachnoid here. This is in the brain. So an intercerebral hemorrhage or interparenchymal hemorrhage here. Keep going. And then stop there. Intraventricular hemorrhage, so blood in the ventricle with hydrocephalus. She's found to have a right posterior communicating artery aneurysm here. That's 8 millimeters. And so she gets, of course, her exam's poor. Right when she comes in, she gets intubated. EVD is inserted. After we insert the EVD for hydrocephalus, she actually gets better. She goes from extending to localizing. And so that's kind of amazing. So the hydrocephalus was causing part of her issue. And then she gets coiled. This is hospital day 1. She's still localizing after the coiling. On hospital day number 3, she gets a EKG with ST depressions. The troponins are only mildly elevated. I still remember this lady. This was many years ago, but I still remember her really well. All of a sudden, out of nowhere in the unit, she's like been coasting, right? Intubated, stable. She becomes hypotensive, like extremely. She's like put on, levo, phenol, and she's still going down, still declining. We put her on dobutamine. Next thing you know, she's PEA, codes, dies. And it's like, whoa, she was like, we're kind of like looking forward to her doing well. She got that EVD, she got her aneurysm coiled. What happened? And so these are two things that happen with not just subarachnoid. It happens with subarachnoid. It can happen with any severe brain injury, with neurotrauma also. Neurogenic stunned myocardium and neurogenic pulmonary edema. They both have similar kind of like why it happens, but it's not fully known. But really, your brain is getting ischemic. It's got severe injury. As you know, that at that point, when your brain's ischemic, you have a very strong sympathetic load going out. That's why you have Cushing's, right? You get super hypertensive when you have severe injury to the brain, because your brain's trying to get more blood. So it's setting out a strong sympathetic discharge to your body to increase your blood pressure, increase your heart rate. And so the mechanism is thought to be that this high increase in sympathetic outload to the heart leads to the heart to get ischemic. It also can develop, you can also develop spasming of the coronary arteries, which leads to more heart ischemia. And that can just lead to like a very quick kind of like a not a cardiomyopathy, but similar to that, like where your just heart just cannot pump. It's getting ischemic. Similar neurogenic pulmonary edema is kind of the same. You all of a sudden get this kind of ARDS picture very, very rapidly. That again is also thought to be this very strong sympathetic output that's coming from your brain because it's getting ischemic, and it causes you to get pulmonary edema. You really, for that, you do ARDS protocol, but it's very rapid. Have y'all seen this every once in a while? Yeah, and it's just like, it will just, out of just one second, they're doing great, and it's just this. And you just do supportive care, right? Put them on pressors, the ARDS protocol, but sometimes you can't change the progress, but it's really the sympathetic output that's coming that's just so high that their heart just can't deal with it, or their lungs can't deal with it. So that's it. If y'all have questions, just remember, like, there's a reason why we're watching that neuro exam so crazy, and especially in subarachnoid. They're doing great 1 second, they decline the next second. It's we definitely appreciate everything y'all do at the bedside, because it's hard, especially patients that are really sick and intubated, trying to get an exam every hour. But it's really, really important, because as you saw, the first 4 of these are very easily, not easily, but they can be fixed. And then you can have patients like Dawn who walk in, and subarachnoids like If you can, I always see subarachnoids, if you can get them through those first 2 weeks that are like this, good one day, bad the next, worse the next. And if you can catch those neuro changes and get them through it, you have a lot of patients like her. She's just one of many that I've seen in my career where I thought, man, this person's never going to make it. And then 6 months later, they like walk in and tell you, thank you for everything you've done. And so it really comes, the heart of this care starts with y'all catching these neuro changes. And now y'all can think this list. And this is the list. If you call me and tell me I got a patient with neuro change, I go through that. This is the list that I go through. I think, okay, re-rupture hydrocephalus. Let's get a CAT scan. Are they hyponatremic? Let's send a set of labs. Oh, well, that's negative. And they're at day 6, 7. Oh, they must be in spasm. Let's increase their blood pressure. So these are the things that go through my head, and they can go through your head too, or these 4 things. Those are the 4 most common things that cause a decline in neuro exam in a subarachnoid. And it's really the same protocol, honestly. Get a CAT scan and look for re-rupture. If that's negative, let's check a stat sodium on them. And if that's negative and they're at the time of spasm, it's really getting their blood pressure up and then watching their exam. If they don't improve, they need to go to angio, right? If we've done all that, they haven't improved, they go to angio. But catching this really changes their outcome. And so questions, thoughts? Yeah. Yeah. Yeah, I mean, I think what a good thing to train the medics on is like that re-rupture thing. Really, out of all that stuff, the one that like is the most important is at the beginning is re-rupture. Because these people, I think of an aneurysm really as like, it's like a balloon and it pops somewhere and the body somehow sealed it off, like with a clot or with brain pushing on it, it's sealed off. But that thing can re-rupture. And if they re-ruptures, their chance of doing well is a lot worse. And so the one thing we can do, all of us, is blood pressure management. So it like makes me cringe when I see a ruptured aneurysm and then an hour later their blood pressure is like 190. I'm like, this is like the one thing we can do to prevent re-rupture is like get their blood pressure down. So I think a big thing to train on is just, it's really important. And especially for long transports, that blood pressure is not always continuous. And so, I mean, it can be 110 and then next thing you know, it's 280 or 240. And controlling the blood pressure, I think, is a really the big thing for transport, just knowing, just kind of, you got to keep it under 140 or 120. And then, of course, if they ever have a declining exam, just intubate them. And if you're having other thing that like our medics in Houston that we talk a lot about is like out more rural, as we get outside of Houston, they're coming in. We tell them, if you're having trouble with blood pressure management, like, and this is what we do even in the hospital, if like it's a ruptured aneurysm, you can't get them down, we intubate them, put them on propofol. I mean, that's really the next step. If you've used all your medicines, I'm not sure what your medics can carry on board and give, but if that's failing, intubate them. I mean, that's really the next step if you have a ruptured aneurysm and you can't control their blood pressure acutely in the beginning phase. Any other questions? Yeah, of course. Oh, just bring in the mic.
Is there ever a situation where if the patient is not, if say their serum sodium is normal, low normal, but their serum osmolality is elevated for the other factors, would you still consider salt tabs or 3% if their osmolality? Essentially, would you consider trending osmolality versus sodium for a subarachnoid or someone with cerebral edema?
Oh, yeah, so kind of different. So I mean, if they're hyponatremic, yeah, we're definitely gonna try to bring them up. But I mean, Dawn, my guess is she probably had high ICP. She got a hemicranie. So for there's certain subarachnoid hemorrhage patients where we actually are worried about high ICP, and at that point we'll try to elevate, right? Do hyperosmolar therapy to really bring up their sodium. That's kind of like a different mechanism. That's really us wanting to control ICP. And so that'll go kind of down that whole ICP management side of things, which you're correct. I mean, at that point, we would elevate it, watch their osms and elevate their sodium level. And that's really kind of for ICP management. And
But so there's not really an instance where if your serum os was elevated and they were showing that they were, and their sodium was essentially like
normal.
140. Would you?
Yeah,
still
no,
want
we
to-
would just leave it then. I mean, we wouldn't try to do anything. Any other questions? Those are good questions. All right. Well, thank you all for having me. It was great. If y'all want the slides or something, I can send them.